Welcome to AATS Mitral Conclave 2017. I'm Dr. Randy Martin, and I'm thrilled to be joined by my friend and guy who's taught me a lot, Dr. Randy Chitwood. Randy, good to see you.
You've taught me plenty too, Randy.
That's good. We got two Randys.
That's right.
So you've done so much in mitral valve repair, robotics, and all that stuff. But I want to go in a little. I want to take you inside the left atrium. Tell me a little bit about the management of the left atrial appendage. Patients who come to the OR in or out of AFib, how do we manage it?
Well, I think we have to manage it in patients with atrial fibrillation, whether it's long-standing atrial fibrillation or paroxysmal atrial fibrillation. If somebody's had, one or two bouts of paroxysmal atrial fib, some people say, well, you don't need to do this. But we certainly do, because we know that there's a high incidence of stroke if you don't manage it, especially in rheumatic heart disease.
Sure.
So in general, if we're doing a mitral valve repair, we would always manage the left atrial appendage. But there have been many ways to do it, some good and some bad. We've learned a lot.
So you're saying even if they've had proximal AFib, you're gonna do something.
I'm going to do something.
So how do you do something to the LA appendage?
Well, I think, usually do it concomitantly with a maze procedure, whether it's just a left-sided or a complete maze, where you would do the ablations on the right and left side.
Sure.
But early on, we would do purse stringing, thinking that was going to be fantastic. It's easy to do, straightforward, but then the Cleveland Clinic and others, us included, found that a number of those leak. Then later on, people said, well, you can just over-sew it.
Okay.
And with a two-layer, but there were still some leaks. Then people were stapling it. Now this is through a sternotomy. We're stapling it, and there was a 25% leak rate. And a leak rate is worse than not doing anything, because basically there's a higher incidence of thrombosis when you do have a leak. So several people at the Cleveland Clinic came up with the idea of putting a clip to ablate the appendage. And that's really my preferred way of doing this, because virtually in the literature, virtually 100% of those atrial appendages are ablated, occluded, and they're occluded at the left atrial wall, so there's no pocket.
So you do this externally, obviously. You come in from the outside and clip it?
Well, if you're doing it minimally invasively, you now can go through the transverse sinus and clip the appendage with one of these devices, because now they're articulating.
Okay.
In the past, what we would do is, we were doing a robotic case, we would do a double layer closure.
Okay.
Clearly a double layer closure.
Okay.
And very few of those leaked, but some did leak. But now what we prefer is to go through the transverse sinus and put a clip if you're doing it minimally invasively.
Right.
Now obviously, if you do through a sternotomy, it's fairly easy just to lift the heart up and put the clip on. But it definitely has to be occluded.
Randy, would you never amputate the appendage?
Well, in the past, a lot of people have amputated the appendage in oversewn. That was part of the original Cox-Maze procedure. But I think today, with the clip, less and less people are amputating it.
Okay.
I would always invert it inside to see how big the appendage is, if there's any clot in it.
Okay.
Then I would sort of dunk it back and do a double layer closure, closing the lips of the atrial of the atrium together. You have to be careful when you do a double layer closure, because the circumflex artery is very close. You're up close to the left fibrous trigone, you've got the circumflex artery there, and so you just want to get sort of the endocardium and not too deep stitch.
Okay.
But with the clip, it's a no-brainer, you're not in that area.
So, final question I have, what about all the transcatheter approaches today? What are your thoughts about those?
Well, the Watchman study was positive, but there were still some leaks. Also, as a surgeon, I prefer not to have a big device left in the left atrial appendage. So I think in time you're going to compete with the transcatheter method if it's a surgical method. However, in some patients who absolutely can't be operated on, and you don't have any other option, transcatheter approaches are very good. I've certainly learned over the years that transcatheter approaches are not the big bad wolf. That we have to use a blended therapy to treat our patients.
And pick the appropriate therapies for the appropriate patient. Well, listen, you've educated me again, and you've educated all of us. Thank you so much for joining us.
Well, thank you very much for asking me to talk.
Super, and thank you for watching.